And I started concentrating on esophagus since 1992 when I was working with my chief who used to operate a lot of esophageal cases. Dysphagia is a very distressing symptom one can have. The simple pleasure of eating is something we often take it for granted. It's a basic human need or need for every creature in the world, but also a source of joy and comfort. The taste of a delicious meal, the satisfaction of full stomach, the social aspect of sharing a meal are all that we enjoy. The inability to eat highlights the limitation of our body, and it's a reminder that our bodies are subject to decay and disease. This can lead to a thought on the nature of existence and the shortness of all things. When the food is taken away, the significance becomes evident. It can lead to a great appreciation for the abundance that often we take it for granted. Inability to eat can lead to feeling of frustration, anxiety, and despair. It can be a reminder of the fragility of life and the importance of cherishing every moment in life. Unable to swallow one's own saliva or unable to eat and drink is a distressing and frustrating situation which attracted me to the field of esophageal surgery. What does it mean to restore a patient's ability to swallow, to taste, to savor life's simple pleasures? As esophageal surgeons, we have the privilege of answering this question every day. Cancer presents a complex journey marked by uncertainty. It's a disease which can impact anyone regardless of background or lifestyle. The delay in diagnosis is a major challenge in esophageal cancer, hence we got patients in advanced stage. And simple to say that if the patient presents with symptoms like dysphagia, patient is in advanced stage. And I can say that I have not operated a single patient in the last 5 years, primarily, and all patients underwent neonatal treatment. And see the smiling, happy face of the patient who had undergone esophagectomy. And I say, while I started my early surgical career, that's in 1992, my chief used to operate on a lot of esophagus. I was really excited while looking at the location of the esophagus, the anatomy of esophagus, the intricate dissection, the complex procedure, the delicate reconstruction, and it was a moment that forever changed my career path. And another thing, opening the chest, looking at the beating heart, and seeing the esophagus in the chest was also fascinating. Right? But we know that in the 20th century, esophagus was operated by great style wards, and the results was not very good because of the supportive care and a lot of other facilities which were not available at that time. And it was not an area, it was an area which was not treated upon even by the middle of the 20th century. Franz John A. Torek, he has operated this for first successful esophagectomy was performed by him in 1913, and he could connect the end-to-end. The most important thing is that every part of the gastrointestinal tract can be resected and reconnected. End-to-end anastomosis is possible, but this is not possible in case of esophagus. And if you resect the esophagus, it will contract to 25 to 40%, and we will have to reconnect it with some intestine. The results were not very good because of poor selection of cases, and preoperative optimization is very important, and the surgical equipments are also important when we operate on such complex cases. So success is all the way if we have all these facilities and if the technique is good. Mortality and morbidity is high in low volume centers. Literature says that more than 6 cases is a high volume, but I always consider that more than 20 cases per year could be considered as a high volume center. And the results are much better when compared to occasional surgeons. The poor results, the reasons for investigations were not available even before 90s. CT scans were not very common in all areas. Inadequate assessment was another reason. Neoadjuvant treatment was not popular, And anesthesia services a lot of things. They say one-line anesthesia, pain management, it was not very good those times. And we were having the rigid esophagoscope and the poor X-rays, then the poor theatre setup, instruments and all those things, and the palliation was done with something like most Robin tube or a feeding gastrostomy or a feeding vaginostomy those times. Definitely, evolution has, or the advancement has taken place in every walks of life, and we know that this is every day it is improving. And we were on Euro cards, but now we have Airbus A380 which can carry 1,000 passengers. And similar advancement has taken place in every aspect of surgery also. So here we can see that we do have better endoscopes and 256 slice CT scan now endo ultrasound to assess the layers perfectly, bronchoscope, and newer stents are available, covered and uncovered stents are available for the palliative treatment. Neoadjuvant treatment also has come in a big way. And we have precision radiation. Previously with the cobalt radiation when we operate, we have a feeling that there is no differentiation or that we cannot separate the esophagus and the aorta. So that sort of local problems are not seen when we give radiation to the patient now with the precision radiation. And newer equipments are available with the help of staplers or operating time has reduced very well. Even for bursting, to put a bursting, there is a bursting device. Endo staplers are available. Newer energy devices are available with which we don't need to transfer sedation, and the newer anesthesia techniques, the one-line ventilation, epidural analgesia, the modern theatres, critical care facilities, everything has contributed to the better or for better patient care and better outcome. We know that more than 5 lakh cases of esophagus is there in the world every year, and it is considered as the 11th most common cancer, but for men it is 7th and for the female it is 13th. And there is no doubt surgery is the gold standard of care in esophageal cancer, but we get patients in advanced stage, so definitely most of the patients will have to undergo neoadjuvant treatment like chemotherapy and radiation. So looking back to my olden days, the black and white photograph is my professor T.S. Warrior, who was doing a lot of esophageal cases in Calicut Medical College. And then the person in the middle has refined my techniques and has taught me throughout and even now. And it is headed by the Professor Chandramohan. I am sure that most of you are familiar with Professor Chandramohan. And it was a very long association with Professor Chandramohan in esophageal surgery. And I had the fortune to work with Professor Mark B. Oringer, who was the pioneer in esophageal surgery and the originator of transarterial esophagectomy, and with Professor Masahiko Surumaru at Tokyo, who was the immediate assistant of Akiyama, who popularized the 3-field lymph node dissections, and with Professor Simon Low at the University of Hong Kong, who were doing a lot of video-assisted thoracoscopic surgeries and popularized the thoracoscopy, and he's written almost 105 chapters in various textbooks about esophagus. And the head of the Department of Surgery at Hong Kong University, Professor John Bong. The primary goal of esophageal malignancy treatment is removal of the tumor, that is the esophagectomy, and removal of the lymphatic tissues. There are several procedures, but the expertise of the surgeon is very, very important. The predictors of long-term survival are arterial resection and lymph node surgery. Neoadjuvant treatment is given to T3 and T4 carcinomas and non-positive patients. Definitely they undergo chemo radiation. And the rules of resection margins are in adenocarcinoma, we have to take at least 5 cm above and 5 cm below the lesion. But the recent literature says that if 5 cm is not available, 2 cm is sufficient, and the length of the spread of the lesion in adenocarcinoma is found to be around 1.8 cm maximum. But it is totally different in case of squamous cell carcinoma. The submucosal lymphatic spread is around 10 cm, so we have to have at least 10 cm resection. So up to 24 we will be able to resect, but more above 24 generally the treatment is radiation. But in early cases we can go for a 5 cm resection above, but the chance for development of a secondary or a recurrence is to the tune of 15 to 20%. And skip lesions are also common. In the second slide, you can see in the red mark is that skip lesions are common. If we take only 5 cm, there can be a skip lesion in stomach carcinoma. Two-field lymphadenectomy, I perform two-field lymphadenectomy. I don't go for the three-field. The three-field Japanese has found that one of the best procedures, and nobody could replicate the results of Japanese, and the survival rate for Japanese is much better with three-field lymphadenectomy. But the problem is the lymphoria and the post-operative morbidity is very high, and some of the patients stays in the hospital for 2 to 3 months after surgery in Japanese patients. The selection of the substitute is either it is stomach. If stomach is available, stomach is the one which is used. If stomach is not available, that is most commonly in patients who are having strictures, we go for colon transposition. And jejunum is not used in the neck, but below this esophageal we can use that. We go for a total esophagectomy, that means a total thoracic esophagectomy, or in some cases total esophagectomy and total gastrectomy may be required where we need a colon replacement. The other one is post-bipod carcinomas. Generally the primary treatment is radiation, and if post-RT failure occurs, definitely we'll have to go for a pharyngeal esophagectomy. You can see these are all procedures which were done in the past: dividing the right rectus, traversing the midline, dividing the left rectus, opening the left chest, opening the diaphragm, reaching the hiatus. But in the minimally invasive era, there is no need to go for such an extensive incision, dividing the cartilages and diaphragm and reaching the left side of the chest. It actually prevents the procedure because the left heart will be weakening, and it will be difficult for us to operate, but much better exposure is obtained even with the midline incision and dividing the diaphragm. AgraMy is definitely it's a procedure where there is a low esophageal adenocarcinoma, and the 5 centimeters of margin which is required, and maybe neck anastomosis will be overdue, but if possible, chest anastomosis can be avoided because the leak which occurs in the thorax can cause death, that is to the tune of 60%, but neck it is less. And this is again opening the 3 areas in neck, right chest and the abdomen, McEwan's procedure. Again, minimally invasive era, there is no need to go for all these procedures because it is very easy to perform the procedure with thoracoscopy and laparoscopy. Transhiatal, definitely the procedure is required in some patients because some of the patients who are having pulmonary problems, this is one of the best procedures, and if the lesion is very early, probably this can be chosen for esophagectomy. And now you can see the scar on the chest and the abdomen. Thoracoscopy and laparoscopy gives much better benefit for the patient, and surgeon also is benefited because the root of the neck and evaluation of the root of the neck, surgery on the root of the neck, and also towards the gastroesophageal junction is very easy with the thoracoscope, and this is the procedure of choice now. And the conduit can be placed in the subcutaneous route, substernal and posterior mediastinum. Again, this is not used nowadays, subcutaneous placement of the conduit. And substernal placement is mostly done by Japanese because the development of the carcinoma stomach in the transposed stomach is to the tune of 10%, and so they always keep it in the substernal, but I think in India we all keep it in the posterior mediastinum. Japanese, they always keep it in the substernal area so that if a second malignancy occurs in the stomach, they will do a sternotomy and they will take out the stomach and keep the colon. And that is a common rule, posterior mediastinum. And this is reconstruction is mainly done with stomach, as let's supply is reliable, two-fashionable CC, and gastric function is preserved. It has got excellent length, and there is only one anastomosis. And the prerequisites for the anastomosis, it holds good for every anastomosis: good vascularity, adequate lumen, tension-free anastomosis, and a good technique. You can see that this is the pharyngeal esophageal. I'm just showing this to say that the length of the stomach is never a problem to reach the root of the neck or to anastomose to the esophagus. So length of the problem is not a problem even after performing a pharyngeal laryngoesophagectomy. We will be able to anastomose to the posterior part of the neck. You can see that the vasculature is maintained well. If stomach is not available, then the next option is colon. I always prefer left colon. Many surgeons use right colon as the conduit. Right colon, there is a problem because a lot of fat will be there in the mesocolon, and sometimes the cecum, bulky cecum will not reach the neck. In that case, we'll have to go for a manual stenotomy, or the distal part of the ileum will have to be anastomosed. Jejunal interposition, when there is a G-junction tumor, or if we do an upper partial gastrectomy, one problem which can occur in the postoperative phase is reflux, alkaline reflux. To prevent that, 20 centimeter of the jejunum can be interposed so that esophageal and a jejunal gastric anastomosis can be performed. And then the mediastinal dissection and the transnasal esophagectomy. I'm going to highlight only the important points. One important point is that never use any metal retractor in the abdomen. That is my finger in the neck. Never use metal retractor when we dissect the abdomen. We can use a mesogastric tube connected to the esophagus so that we can pull it. The heavy metal retractor will compress the cardiac chambers and that can result in problems in the post-op phase. So the thoracoscopy is done with 3 ports, 1 camera port and 2 working ports. Another 4th port can be used, but I always use only 3 ports. I'll just show a small clip on thoracoscopy. The vision is excellent because now we have 3D, 4K and 4K. All these optics are available. You can see the esophageal vein, root of the neck, and the dissection starts from the inferior divide and the inferior pulmonary ligament. And that is the start from the medial lateral border. And then we proceed further. The lymph node dissections are done. And it is very easy to proceed with harmonic scalpel or ligashua, which can control all the weight. We can see the pulmonary vein just below that. Now the esophageal vein. Esophageal vein is isolated. You will find the bronchial artery there. Bronchial artery is controlled. In all cases, bronchial artery is not ligated, but if we ligate bronchial artery, there is a possibility for bronchoria, and postoperative morbidity can be high. Now the esophageal vein is clipped and it is divided. I used to keep the esophageal vein and proceed in the initial 2 cases, but I not found any advantage for doing that. So now in all cases, esophageal vein is divided. You can see the bronchus there. Now that is the pleura on the other side, close to the just below the esophagus. You can see the thoracic duct. In all cases, thoracic duct is isolated, identified, traced up to the gastroesophageal junction. To avoid this, I'll be talking about the complication and I'll mention about that at the time. The thoracic duct is split and all the fat and fascia in front of the aorta is taken so that the lymphadenectomy is complete there. There are a lot of lymph nodes you can see there. Now the dissection is going towards the gastroesophageal junction. And up to the junction we can clearly dissect out, and we have to be careful for the IVC in the lower part. Now the dissection is going upwards. So another important point is that you can see the division of the esophagus and the neck. One has to be very careful here because when the muscle is incised, the mucosa retracts. So the mucosa should be divided at least 0.5 to 1 centimeter beyond the muscle cut. Otherwise, now you can see that the mucosa is coming at par with the muscle. So if we divide it at the same level, there is a possibility for not including the mucosa in the anastomosis, and the anastomosis can fail. And construction of the stomach tube also is very important. I will never allow my assistant to touch the stomach during esophageal or stomach mobilization, because the stomach is surviving on 3 vessels from the right gastric artery and from the right gastroepiploid. The short gastric, left epiploic and the left gastric arteries are divided. And you can see 4 to 6 centimeter diameter of the conduit is required. and it should not be a conical stomach at the upper end. So the first division is done at the incisional level after the 3 vessels, so that the stomach becomes straight, and then we can proceed to the upper part. The stomach should be parallel and it should be 4 to 6 centimeter diameter. You can see there are no petechial hemorrhages, and more than 50% of the area is not supplied by direct vessels. It is supplied by the vessels from below, and so if we hold the stomach each time, the stomach vessels are damaged, and that can actually contribute to leak. So prevent or minimum handling of the stomach is what is required. And anastomosis, we can do anastomosis with several techniques and several materials can be used. But now, for the last many years, I use anterior and posterior stapler. One of the major problems is stricture. I'll be talking about that. So here, you can see that the posterior part of the stomach and the posterior part of the esophagus is anastomosed with one stapler. About 4 to 4.5 centimeters of the stapler is introduced, and that is fired, and the anterior portion also is stapled, so that we get adequate room for anastomosis, and stricture is never a problem in this. But we should understand that end-to-end anastomosis is likely to cause stricture. End-to-side also can stricture, but stapler anastomosis, when we create a wide anastomosis, nothing goes wrong, and stricture is not a problem in esophageal anastomosis at all. And you can see in the literature, 15 to 20% of stricture is possible, and dilatation and repeated endoscopy are required to manage this, which can be completely prevented by making a wide anastomosis. That is the anterior stapling, and the anastomosis is performed in no time. Continuous anastomosis actually can cause stricture rate, or interrupted anastomosis, the ischemia developing at that area is around 10 to 15%. Continuous anastomosis causes 25%, and stapler actually causes 40% ischemia, but it survives very well because of the vascularity. You can see the stomach and the esophagus get out much of petechial hemorrhages, and what they always say, pink in the abdomen and pink in the neck. That's the rule. So I'll be talking only about 3 complications. I don't want to highlight all the other complications, but these are the 3 complications which a surgeon who performs esophagectomy stop doing after the procedure or after attempting 1 or 2 cases because of these major problems. The anastomotic leak, I was talking about the handling of the stomach, keeping the vascularity safe. And when we transport, we have to be extremely careful. There should not be any risk for vascular injury, for which a plastic bag can be used and which can be used for transportation. And check the vascularity when it reaches the upper part. In case if there is any doubt, take the stomach back to the abdomen and then check it, and then only anastomose. And if there is a problem, resect that portion of the stomach and then anastomose. And you can see this is a patient who had esophagectomy. You can see a note there, so definitely it is not a new case. It was a patient presented to the local doctor, and he tried introducing the esogastric tube. Always there will be some angulation at the anastomotic area. So that healthcare worker tried nasogastric tube, and it came out through the old incision. You can see that it is leaking from the anastomotic site, and when there is leak, usually there will be a small abscess there, and redness, features of inflammation will be there. Sometimes when we keep the anastomosis here, it can slip into the root of the neck or into the thorax if we keep long length of esophagus. Otherwise, it will be contained in the neck only. And if leak occurs, definitely we can ask the patient to take food. That is, solid foods he can take, but liquids we can try through the feeding tracheostomy. The solids, he can keep a pad and he can have solid feeds. There is no need to stop feeding in a case of neck leak. But thoracically, we have to drain the chest, we have to go for the stenting, but depending upon the situation. I was talking about the stricture. Any type of anastomosis can be performed, but the best anastomosis in the literature which I found is a posterior and anterior stapler into anastomose and a continuous suture can definitely cause strictures. And this is, in all cases, I used to identify the thoracic duct. The post-operatively, if you try to identify the thoracic duct, it is going to be a difficult problem because it will be leaking and the thoracic duct will not be dilated. Now you can see that the Esophageal vein there, and just above that is the aorta. The esophagus is now exposed. And I'll be walking along the transverse line of the esophagus so that I can see the fat pad just below the esophageal vein and in front of the aorta and in between the esophagus. It's very easy to find out the thoracic duct. Now I'm going to retract the esophagus. You will find a fat pad there. And in that fat pad you will find the tubular structure. And just like a duct. Now the thoracic duct is visible there. That is the thoracic duct. And this can be traced throughout till we reach the gastroesophageal junction. The problem in the post-operative phase is that once we operate in those areas, it will be very, very difficult to find out the thoracic duct, and occasionally after neck dissection, sometimes it leaks from the neck and we will be able to expose the thoracic duct and clip it there. In esophagectomy in cancer, I used to take out all the fat and fascia in front of the aorta and I will be completely dead, and the thoracic duct will be taken out to the gastroesophageal junction. So the advances in technology, the understanding of wound care, intensive care facilities, nutritional support, anesthesia services, everything has made esophageal surgery look as easy as any other conventional surgery. Every year, thousands of individuals are diagnosed with esophageal cancer, a disease with devastating impact. As surgeons, we have unique opportunity to improve patient outcomes and long lives. As we look into the future, I urge the next generation of surgeons to take up esophageal surgery and strive for excellence. I'm very happy to have had the opportunity to alleviate the suffering of a fellow human being with difficulty in swallowing, a very basic need for survival. My journey in esophageal surgery has been a privilege. Every day I'm humbled by the opportunity, and the human body is a masterpiece of engineering. As surgeons, we have the privilege to restore it. With great respect to my teachers and my patients. Success is no accident, it's hard work, perseverance, and learning, studying, and sacrifice, and most of all, love of what you're doing.